Hello and welcome to another emergency questions and answers for families in ICU and intensive care at home. My name is Patrick Hutzel. I'm the founder of intensivecarehotline.com and also the founder of intensivecareathome.com, and I will be your host today. We'll be going roughly for the next hour where I answer your questions, and you can pop them into the chat pad, or you can connect with me directly here with a link that I'm just posting into the chat pad. Now, first of all, Merry Christmas to you and your families. For us here in Australia today, it's Boxing Day, and for most of you watching this, probably in North America, and it might still be Christmas Day. And I know if you have a loved one in intensive care, it's a very difficult time of the year. And I just want to reassure you that we are here to help you whenever you need us, even at this time of the year. Okay, so now, what makes me qualified to host an emergency questions and answers for families in intensive care and intensive care at home? And what makes me qualified to answer all these questions? Well, once again, I'm a critical care nurse by background. I have been working in critical care nursing for 25 years in 3 different countries, where I worked as a nurse manager for over 5 years in intensive care. And I've been consulting and advocating for families in intensive care since 2013 at intensivecarehotline.com. And I can very confidently say that we have saved many lives for our clients in intensive care, and we have improved many lives for our clients in intensive care. And you can verify that on our testimonial section, and you can verify that on our intensivecarehotline.com podcast section, where we have done client interviews. Also, with intensive care at home, again, we are helping so many clients living their best lives at home instead of intensive care, right? And you can find more information there at intensivecareathome.com. With intensive care at home, we are sending our critical care nurses into the home for predominantly long-term ventilation and tracheostomy, but also for BiPAP ventilation without tracheostomy, tracheostomy without ventilation, home TPN, home IV potassium, home IV magnesium infusions, but also central line management, PICC line management, Hickman's line management, as well as porta cath. We're also doing ventilation and tracheostomy weaning at home. We're also providing nasogastric tube and PICC tube management at home, as well as all catheter management. Okay, without further ado, I do want to go into today's questions, and I want to start with a question that we get quite frequently for intensive care at home. And the question for one of the questions that we get for intensive care at home quite frequently is, can a ventilator, tracheostomy, and PICC tube be removed at home with intensive care at home? Well, that is a great question, and right away, the first thing that comes to mind is, first off, we have done that at home successfully, but one client or patient group, whichever way you want to call it, that comes to mind straight away is when patients are faced with Guillain-Barré syndrome and they're stuck in intensive care with Guillain-Barré syndrome. So let me elaborate. During my time in intensive care, when I worked in intensive care as a nurse, right, there were a number of clients or patients with Guillain-Barré syndrome. Now, what always goes hand in hand with Guillain-Barré syndrome is long-term stays in ICU for ventilation and tracheostomy weaning, right? And I've seen Guillain-Barré patients in ICU for 6-9 months, and the only thing that's keeping them there really is ventilation and tracheostomy. Yes, sometimes they get IV immunoglobulin as a therapy that could be done as an outpatient, or it could be even done at home, right, with the right level of support. So what those Guillain-Barré patients have in common is that they all need to be liberated off the ventilator, the tracheostomy, and the PEG tube eventually. Sometimes they don't even have a PEG tube. Sometimes they're perfectly fine with a nasogastric tube. And you would have heard me talk about in countless other videos that a PEG tube is not necessary for someone that's on a ventilator temporarily. And I argue that the overwhelming majority of patients that have been diagnosed and had Guillain-Barré syndrome do not need a ventilator in the tracheostomy in the long run. Okay, so, but it doesn't really matter whether it's a nasogastric tube or a PEG tube at home. We can wean either. And just before I forget about it, if you like my videos, subscribe to my YouTube channel and give the video a like, and share the video with your friends and families, and click the notification bell as well. So, how is it done? How can we wean a ventilator, tracheostomy and PEG tube, or a nasogastric tube at home with intensive care at home? So first off is, we need to establish the right teams for the right clients, right? So what that means, selecting a team of critical care nurses for our intensive care at home patients, a lot of it depends on location, of course. While we're now operating all around Australia in all major capital cities and in all regional and rural areas, finding staff in a metropolitan area is easier than finding staff in a remote or regional area, of course. So that goes without saying. But the bottom line is, we have highly skilled teams out there on the road that keep our clients safe and out of intensive care, and we're basically replicating the intensive care bed in the community, for dozens of clients in the community, and we can do the same for you. And so number one, it needs to be safe. There needs to be a 24-hour roster with critical care nurses 24 hours a day. Number two, there needs to be medical oversight. Of course, someone needs to oversee ventilation, tracheostomy weaning, needs to oversee medication management, pathology management, and so forth, right? So that is next, right? And then what is also happening at home, all of our clients without exception have community access. So what that means is, in an intensive care unit, clients or patients will not leave intensive care, right? They're stuck in their ICU bed, stuck in their ICU cubicle, whichever way you want to name it, and, sort of the best thing that I've seen is maybe patients getting over to a window in an ICU. If things are really going well, they might get into the courtyard for 10 minutes, right? But that is not the same than being at home, surrounded by your loved ones, and being able to live your life the way you see fit, even though you have a critical illness or a critical and a chronic condition, right? So going home is the much better option, and it's safe. And, and those are the things that need to be in place in a nutshell. I know it sounds overly simplistic, but that's what it is. You need a critical care nursing team, a home care critical care nursing team, an intensive care home nursing team, and you need medical oversight. Of course, you need more than that. You need a physical therapist coming, a physiotherapist coming. You need an OT. You need a speech therapy dietitian, of course, similar to a hospital, But that can all be organized and all be arranged. Even things like, chest x-rays can be done at home now, pathology, taking bloods can all be done at home now. No need to go into a hospital that's full of infections, full of bugs, where patients are much more prone to get an infection, right? At home, it's a clean environment. It just makes perfect sense to continue treatment at home. right? From a cost perspective, also keep in mind that an intensive care bed costs around $5,000 to $6,000 per bed day. A home care bed with intensive care at home costs around 50% of that. That's about half of that, right? Plus, the intensive care unit needs a bed, desperately needs a bed. Intensive care beds are the most sought after beds in a hospital, right? So once again, it makes perfect sense that home care is being initiated and carried through, right? So that patients can live their best life out of the hospital and intensive care system, right? So that families can live their best lives outside of the intensive care and hospital system, right? So it just makes a lot of sense that intensive care at home is initiated in those situations, right? Now, I will also say that if a PEG tube can be removed, I argue the PEG tube wasn't needed in the first place, right? So what do I mean by that? You've heard me say in other videos that we are very much opposed to PEG tubes, right? Here's the reason why. You know, a PEG tube, with a PEG tube, health professionals have the perception that a person with a PEG tube will never eat and drink again. Now that's a perception. It's a very negative perception, and I hope it could be changed. But you know, I think it's true in the bigger scheme of things that most PEG tubes are permanent, and that patients will never eat and drink again, and that is very sad. That is very sad. Now, similar to tracheostomies and ventilators, PEG tubes have their time and their place. What do I mean by that? PEG tubes have their time and their place if, you know, let's just say a spinal injury client, C1, C2, C3 spinal injury, it's very unlikely that these patients will ever eat and drink again. Other clients that need a PEG tube are clients, for example, with cerebral palsy that are ventilator dependent or tracheostomy dependent. It's also very unlikely that they will eat and drink again. Okay, with these clients or this client cohort, it makes sense to do a PEG. Now, let's come back to our question where it says, can a ventilator, tracheostomy, and PEG tube be removed at home with intensive care at home? You know, the question should also be phrased, can a ventilator, tracheostomy, and nasogastric tube be removed at home with intensive care at home, right? So, we can take patients home with a nasogastric tube. There is no issue. As a matter of fact, we've got clients at home with a nasogastric tube, right? There's really no issue around that. So there's really no issue around that. And if a nasogastric tube can be weaned, which we've done at home as well, right? There is no need for a PEG tube. You've got to make that assessment prior to going home, of course. But a nasogastric tube can definitely be weaned at home, you know, because what a nasogastric tube means in particular is it's temporary, and a patient needs to start to eat and drink again as soon as possible. Now, there are exceptions to the rule where nasogastric tubes are permanent too, but that is mainly around, you know, when someone has, it's mainly around when someone has an abdomen where a PEG tube can't be inserted for whatever reason. But those are rare exceptions. Very rare exceptions, right? So, I hope that clarifies, right? How do you wean a nasogastric tube or a PEG tube at home? Well, with the example of the ventilator, first off, you need to wean the ventilator first, right? Patient needs to get mobilized, needs to pass spontaneous breathing trials, right? Needs to be able to cough, protect their airway. Once that's done, then patients can be started on tracheostomy weaning, right? Tracheostomy weaning, once again, patient needs to be able to cough, breathe, swallow. So cough needs to come down. Then the tracheostomy needs to be capped or needs to be downsized, right? And everything, can go from there. We have decannulated successfully clients at home, weaning off the ventilator and tracheostomy decannulation. Now those clients had a nasogastric tube, not a PEG tube, right? So then once the tracheostomy has been removed as well, that's when you can start with starting to eat and drink again very slowly. A speech therapist needs to be involved in that, because the worst thing that can happen in situations like that is patients aspirating. And if patients are aspirating, that would be a big setback, possibly would need reintubation, or the tracheostomy needs to go back in and ventilation needs to be commenced. So that's why weaning a nasogastric tube or a PEG tube is also a gradual process. The best way I can describe improvements for patients in ICU or with intensive care at home, it's really, the improvements are often gradual, and it's often like switching on a dimmer with a light, and not like switching on a dimmer, and not like switching on a light with a switch. Everything will go probably much slower than you think and that you're hoping for. That doesn't mean there's not going to be any progress. Okay? And I know the word, no one wants to be patient anymore. In this day and age, it's all about quick fixes and instant gratification. Unfortunately, this is not the world that we are living in. Everything happens gradually and often at a slow pace. It can be often 2 steps forward, 1 step back. Right? So I hope that helps you understand what needs to happen when it comes to ventilation, weaning, tracheostomy weaning, and PEG tube / nasogastric tube weaning at home. The other thing that's important to understand, especially when it comes to learning to swallow again after, tracheostomy removal, again, you got to start with thickened fluids, a pureed diet. It's again, the progress is probably much slower than you think, and you will still need to supplement food through the PEG tube or the nasogastric tube while you're weaning that off. So I hope that helps you understand of what needs to happen when your loved one is in intensive care, when your loved one is at home with a ventilator, PEG tube, with a ventilator, tracheostomy, PEG / nasogastric tube. Okay, so now next. Let's go to another question that came in this week. Just bear with me. There we go. And if you have any questions, please type them into the chat pad or connect with me live here on StreamYard. You can connect live with me here on StreamYard if you click on the link that I posted in the chat pad. Now let's read out a question from Valerie that has come in. And Valerie says, "Hi Patrick, my mom has had a bad case of pneumonia, probably from the ventilator. She has been here a month. She has a lot of bed sores. She probably got them in the emergency department. They don't give good care in the emergency department. I left her there alone originally because I got a call while with her that I was closely exposed to COVID and went and got tested. She also got some bad wounds from a C-collar they made her wear. Finally, they put on a softer collar and left it undone unless they move her. She's starting to wake up. They thought she would not, but I did want her to have pain medications. They had to turn up the ventilator settings due to the pneumonia and allowing pain medications. Yes, of course, pain medications would have been morphine or fentanyl, which as a side effect have respiratory depression. The tracheostomy is not healing. They made a huge hole. much bigger than normal for some reason. It is packed with silver. Her white blood cell count is 24 and going up. They think they have her on the right antibiotics. She gets a vancomycin-resistant UTI a lot, but they don't think it's that. The doctor this weekend thinks she's just dying and doesn't want to heal and open her eyes. And opening her eyes is the surge. They say they won't pressure me, but the doctor says they will keep treating her, but they think she's dying. The biggest issue seems to be the wounds she got here. I think I can piece support together at home from the place that rents the ventilators. Her RT says the LTAC is no good, especially with wound care. Yeah, been saying that for the longest. With or without wound care, LTACs are no good. Her insurance is already seeing what we can do about me wanting to bring her home. I have a hospice who might take her with a ventilator, and the place that rents the ventilators has some RT staff. Here RT thinks the settings are basic and not hard. One doctor wondered if she would make it home okay in the ambulance. What if the tracheostomy pulls out in the ambulance? It's a pretty big unhealed wound. I can stall and keep her in ICU longer. I told the doctor I want to take her home, not go to LTAC, and she was shocked. The RT thinks it's possible. Well, of course it's possible. And, of course it's possible. There's no question about the possibility of this. And I'm not surprised that wound care has been an issue. That can be a big issue when hospitals are not doing the right things, when patients are not being attended to in time, and all the rest of it, right? So I'm very sad to hear that. But going home is definitely possible. So I tell you, when going home is not possible or difficult, going home is not possible when patients are in an acute critical condition, like they are on multiple inotropes, they might be on ECMO, they might have had a car accident, God forbid, any sort of accident where they're waiting for surgery and they have broken bones, and then ICU is absolutely the right environment. But as soon as someone is hemodynamically stable, they're off sedation or minimal sedation, they have a tracheostomy, and have a tracheostomy that's well fitted, because it sounds like the tracheostomy is not well fitted, right? And that's when things become difficult. But similar to my first question, a tracheostomy is definitely going home in a situation like that is definitely possible, right? And all it is really similar to our first question, getting a critical care nursing team ready, right? Getting a critical care nursing team ready for home care, right? And, getting a home care ventilator, getting suction machines, getting monitors, setting up an intensive care bed at home. That's what it basically is. Getting some medical oversight. That's what we do here all year in Australia. And I know you're in the US, right? And I know you're in the US. But the same can be done in the US. We can do the same. We can do the same for you in the US. Anyway, so this is all possible. This is all possible, and you're right on the track. You don't want her in hospital too. You don't want her in hospital as well. And you're on the right track, taking her home. It's common sense. It is common sense, and way more is possible. Way more is possible than you think. The only thing that we need to sort out in a situation like that is that the only situation we need to sort out is the collar. Why is she having the collar? Why is she having the collar? Why is she having the neck collar? Right? That's probably the only question. But even a neck collar, we can see we can manage at home. So let's just go back to the question in more detail. Now she's starting to wake up. Tracheostomy is not healing, but part of the issue here as well is that if the tracheostomy is not healing, it means they haven't done the right thing there. Right? They haven't done the right thing there. Why is the tracheostomy site not healing? And is that better to have that healed at home where it's a clean environment? Are we better off at home doing that at home? Rather than having it done in a hospital. And in case the doctor wondered whether she can go home in an ambulance, I would say yes. As long as she's not on inotropes or vasopressors, and you haven't mentioned any of it, but even if she is, a transfer is still okay. Transfer will still be okay. Will still be safe. And the reason I'm saying that confidently, most patients are, there's patients flown around on ECMO machines, right? So therefore, your mom will be safe being transferred in a car, in an ambulance. So I hope that helps you understand once again what's possible with intensive care at home. A lot more is possible than with intensive care at home than you think. Now, there's also talk in your question about hospice, right? And with hospice, for example, we could provide end-of-life care at home as well. Doesn't sound to me like that's what your mom needs right now, but if your mom, God forbid, is approaching end of life, it doesn't sound to me like she wants to approach end of life at home. Right? It doesn't sound like she wants to approach end of life at home. And once again, if she would like end of life care at home, I believe intensive care at home is the much better option here, because who wants to die in a hospital? Right? Research has shown that 75% of people in Western countries want to die at home if given a choice, and yet less than 15% of patients do die at home. Right? So the question is, why? Why are we failing the people? Why are we failing the people? Why are we not listening to the people? Why are we not listening to the people? Why? Okay, so let's move on to the next question, and let's move away from intensive care at home for a moment. Currently, we are working with a client who has their 65-year-old mother in intensive care. She went in there just a few days ago after cardiac arrest with a hypoxic brain injury. And before I go deeper into that, if you have any questions, please type them into the chat pad or connect with me live directly here on StreamYard, and you can talk to me directly here and get your questions answered in a much quicker way. So, currently a client that we're working with, their 65-year-old mom went into ICU a few days ago with cardiac arrest and hypoxic brain injury. And their mother is already off sedation and opiates, and she's sort of slowly waking up. Doctors say it's a poor prognosis, with an anoxic brain injury. It's the usual doom and gloom spiel. but it's only day 5. Patients don't wake up day 5 after an induced coma without a brain injury sometimes. So in this situation, it's going to be very important that you exercise patience, right? So what should the family be looking for here? First off, the family, or our client here, you need a lot of patience here. It's day 5. It's way too early to see where this is going, right? Way too early to see where this is going. And what needs to happen next? And I know she's already breathing in pressure support, which is basically the lowest ventilation mode on the ventilator. That's also a good sign, but she's not awake yet. So what needs to happen here next? What needs to happen here is gentle stimulation by, talking to the patient, doing physical therapy, starting leg exercises, joint exercises, and then starting mobilization, right? The sooner the brain can be stimulated, whether that's with, talking to a patient, especially families when, because families recognize their loved ones' voices, playing their favorite music, maybe smell, surrounding them with pictures from loved ones and all the rest of it, right? And that would be a starting point. But mobilization might also help, right? And a good ICU will start mobilize this patient, right? A good ICU will start mobilize this patient as quickly as possible. And that can be done even though they're on a ventilator. They can be in a tilt table, in a recliner chair. A good ICU will do that. I encourage you to type into Google mobilization of ventilated ICU patient images or pictures, and you will see images and pictures of mobilized ICU patients that are on a ventilator. So it is absolutely possible. And there's enough research out there to suggest that early mobilization will help in recovery, and not mobilizing patients will actually have much poorer outcomes, right, for patients. When a patient is not getting mobilized, not having physical therapy, deconditioning is a massive, massive risk, and it's a massive reality. And patients decondition by the day. It's a race against the clock, right? And any ICU that's not mobilizing, I criticize here, because it's not in the patient's best interest, right? And the sooner patient can be mobilized, the better the outcomes. One of my friends and associates, Carly Dayton, has a wonderful blog and podcast, Dayton Consulting, and she talks about early mobilization in ICU. She verifies pretty much everything that we are saying here. So shout out to Carly. I've had Carly on my podcast here a couple of occasions that I've been a guest on Carly's podcast. So, there's clear evidence there. There's way more benefits than disadvantages, way more benefits than disadvantages. So early mobilization all day, every day. The only time a patient in ICU cannot be mobilized, from my experience, is if they're hemodynamically unstable, right? If they have a risk of, pulmonary embolus, if they have fractures and are waiting for surgery, if they have a traumatic brain injury, they're all contraindications for mobilization. But that is not the case in the example that I've given today, right? So early mobilization, so important. It'll also give you a good idea of how quickly someone will respond, or if they don't respond. It'll give you a much better idea of what to do next, right? Much better idea what to do next, what to look for, what questions to ask, So then, if you have any questions, type them into the chat pad, or connect with me live directly here on StreamYard. You just click on the link that I posted in the chat pad, right? And you can talk to me directly, right? So next question that's coming during the week. 61-year-old lady that's in ICU with a subarachnoid hemorrhage. She had a brain bleed on the 6th of December. She was operated on the 7th of December, and she has remained in ICU since then. She came out of consciousness for a little while, but not for very long, apparently. And for about 2 weeks, the ICU team and the consultant said to the family that there's no further damage to the brain. But on Friday, the 20th of December, they were told that there's significant brain damage, apparently, and they did another MRI scan and CT scan. Now they're saying there's significant damage to the brain, and she will remain in a vegetative state, and she won't have any quality of life if she was going to survive. And that they want the family to come to a decision to turn off life support. And obviously the family wasn't happy about that, and they did some research and they found intensivecarehotline.com, of course, and reached out to us. Now, the first question that I asked the family at the time was, what's changed? Why is she all of a sudden having brain damage that they didn't see before? What has changed, and why didn't they pick up on it? And she didn't really have an answer, and neither did the doctors have an answer for it. It just seemed to happen, right? So the first thing that I advise the family to do is get access to the medical records, right? Because if you can't get access to the medical records, you don't really know what's happened, And now all of a sudden the family also has the impression that she's a number to them. She's a number, Prior to the second CT scan or MRI scan, they thought they were treating her like a human, but now it looks like she's become a number, right? So I asked them to get access to the medical records. The ICU team wants to have a meeting with them, about end-of-life discussions and switching off life support. I said to the client that you shouldn't go into that meeting if that's not the discussion you want to have. You only want to have discussions about how they can preserve your auntie's life or your family member's life. That's the only discussion you want to have. The other question that you need to ask yourself in a situation like that is, where's the urgency to kill someone? Where's the urgency from ICU to end someone's life? Please explain that to me. Please explain that to me. Where's the urgency? Right? Why not try and save someone's life? Right? Why not try and save someone's life? Right? And also what the family has also said is that she's waking up. She's responding to the voices from family. She's opening eyes when the family is around. She's not doing that when the ICU team is around. Fair enough. So apparently she's even squeezing the family members' hands when asked. So how come they're talking about permanent brain damage if there is purposeful movement, meaningful movement? She's responding to commands. So, why are they making this up? Once again, where's the urgency to kill someone? Right? And if you've watched any of my videos for any length of time, my theory has always been that, ICUs are in a hurry to get patients out. And if they can't get patients out in a timeline that fits with the agendas of ICU teams, then often the end-of-life talk is being given, saying, they won't survive, and it's not in their interest to survive because they won't have any quote-unquote quality of life. What a whole lot of nonsense. What a whole lot of nonsense. Put your best foot forward first, and if that doesn't work, plenty of time to talk about end of life. Plenty of time, right? Put your best foot forward first. Give patients best care and treatment, especially if they're waking up. Why don't you ask the patient what they want, especially if they're waking up, right? It's very cowardice of not talking to patients, right? And why do people go into medicine or nursing if they don't want the best for patients and their families? What's the point? Right? And it shouldn't be a medical decision who can live and who can die. It should be a decision of allocating resources, right? So also now it's been 17 days and now they're wanting to start the end of life talk instead of the tracheostomy talk. Now that she's ventilated with a breathing tube for 17 days, they need to start offering a tracheostomy. Instead, what they are offering is end-of-life care, basically killing a patient. That's what they're offering instead, right? And they haven't given this lady enough time. This is the thing. 2 weeks is not a long time. ICU makes it look like it's an extremely long time, but it's not a long time. It is not a long time, right? So keep that in mind, that it is not a long time by any stretch of the imagination, right? So if she's already obeying commands, right? She's already squeezing fingers when asked, right? That's a good sign. That is a very good sign. And why not continue on that path? After 14 days, a tracheostomy needs to be recommended if someone hasn't come off the ventilator, right? If someone hasn't come off the ventilator. So it's now, instead of talking about end of life, it's now time to talk about a tracheostomy. And then, God forbid, if tracheostomy can't be weaned, once again, this is where intensive care at home comes in, right? ICUs need to start listening to what patients and families want, right? And if someone is obeying commands, squeezing fingers, wiggling toes, poking out their tongue, simple things that you ask them for, that means the brain is intact to a large proportion. Now, once again, I've worked in critical care nursing for 25 years, right? Some patients without a brain injury don't wake up straight away. If they've been in an induced coma for days, sometimes weeks, they're not waking up straight away. Once again, it's like switching on a light with a dimmer. It's not like switching on a light with a switch, right? All these medications need to get out of the system first. And when a patient is critically ill in a situation like that, there are dozens of things happening simultaneously. And unless you understand what's happening there, you're really not even understanding half of the things that are going on. This is why we strongly recommend you get access to the medical records, right? You need to get access to the medical records. And once again, what is quality of life? The intensive care team says, well, if she will survive, she will be in a vegetative state and she won't have any quality of life. Well, number one, she's already waking up. Number two, what is quality of life? Who are intensive care teams to say what quality of life should be acceptable for an individual? Right? That's up to the individual and to the family to decide. Our jobs here are to get the best outcomes for patients and for families, full stop. That's the job for us here. And educating people about the outcomes and what's possible, right? A lot of patients with subarachnoid hemorrhage go to neuro rehab. Why not suggest that? Why not suggest that? What's the urgency? Where's the urgency to kill someone? Please explain that to me. Please explain that to me. Okay, so I hope that helps you understand, what options you have. And it's really important that you do understand the options. And another thing that I like to mention in this context is, there's a difference between a real and a perceived end-of-life situation. What do I mean by that? A real end-of-life situation is someone's going to die, and there's nothing that can stop that from happening. When someone is in ICU and they are in a real end-of-life situation, no treatment, no fancy drug, no fancy surgery, no fancy equipment, no nothing will stop your loved one dying. That is a real end-of-life situation. Now, in the example that I've just given you, that's a perceived end-of-life situation. And there's a huge difference. Perceived end-of-life situation is a perception that someone is dying. And it's just that's a perception, right? So it's complete and utter nonsense to suggest that this lady is dying. She's not, because she's actually obeying commands. The intensive care team need to have the guts to talk to her and find out what she wants. Not brave enough. They want to push their agenda. Not brave enough to talk to a patient. Imagine that, talking to a patient. Not part of my job description, talking to a patient. Excuse my sarcasm here, but we need to talk to patients and families. We need to start listening to them, and not approach the one size, not approach patients and families in intensive care with this one size fits all paradigm. So anyway, so we've covered a lot of intensive care territory today, even in the last question. So let's go to the next question, and that came in this week as well. A 49-year-old lady that is in ICU with sarcoidosis. She's not there she's not in ICU because of that, but she now is having a bad reaction. So she went for dialysis, and then she was having a bad reaction to dialysis, right? And then she was on oxygen 24 hours prior to going into hospital because of the sarcoidosis. And then what happened next is, I'm just looking at the email. She's now on a ventilator with a breathing tube. And the family is pretty much asking what's next. But, they're also mixing up a lot of the terminology. Initially, when I spoke to the family, they thought their family member is having a tracheostomy, but it turns out she does have a breathing tube and not a tracheostomy. So getting the terminology right when you have a loved one in intensive care is really important. Once again, the biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights. They don't know how to manage doctors and nurses in intensive care. Right? So, and now they were asking whether she should have a tracheostomy. It's been day 16, right? On a breathing tube, on a ventilator, and now is the time to do a tracheostomy, even though their sister is fully awake. She can't breathe just as yet, right? She's not there yet. So, but what needs to happen as well in a situation like that is the family needs to have access to the medical records. They haven't got that yet, right? But also, what needs to happen is when patients and families are faced with, the issue of potentially having a tracheostomy for their loved ones, what is the intensive care team doing to avoid a tracheostomy? What are they doing to wean a patient off the ventilator and the breathing tube? Right? That is the question that needs to be asked in a situation like that as well. right? And it turns out when I spoke to the family that their family member is still on sedation, still on mild sedation, which won't help with ventilation weaning. To wean someone off a ventilator, you need to take a patient off sedation completely. And you could also potentially do a trial extubation, right? And you could extubate onto BiPAP with a mask, but that also has some risks. The best case scenario here is, either extubate, remove the breathing tube, or do a tracheostomy. There is always a case for a trial extubation in most cases, but you want it to be safe. You don't want it to be risky to the point where, your family member would aspirate. You don't want that. So it also turns out that this particular patient already had a failed trial extubation. And if there's one failed trial extubation, that's a fairly high risk. That another failed extubation is possible, right? So, it's really important that you as families get access to the medical records as quickly as possible. Because once you have access to the medical records, you will actually see why you need help, right? You will see why you need help, because when you look at the medical records, you can see probably a lot of things you have no idea what the doctors and the nurses are talking about. This is where our area of expertise is coming in, where we interpret the numbers for you, where we interpret the medical jargon for you, where we help you understand, are they actually doing the right things, right? Because sometimes they're not doing the right things. Are they withholding critical information from you? You will actually find that when you give us a summary about what's happening, and we look at the medical records, I can tell you 9 times out of 10, they haven't even told you half of what's going on, right? We're finding that over and over and over again. They're deliberately withholding information to create a narrative that is convenient for them. It's all about the narrative, right? And ICU teams are very good at trying to stay in control of the narrative if you let them. You can't let them be in control of the narrative, right? Most examples that I've given you today, it's all about control for intensive care teams. It needs to be about control for you, and you can't be shy about it. The minute you are shy about it, they will walk all over you, right? So once you have access to the medical records, we can break things down for you in much detail, and we can explain to you in layman's terms what's actually happening, right? And what dots you need to connect, what questions you need to ask, what treatment options are there for your family member, right? Once again, half of the time they're not giving you all treatment options that are available for your family member. You don't know what you don't know, right? And it is critical for you to find out what you don't know. Critical. Right? And that's where we can help you very fast. Very fast. Okay. So I'm going to wrap this up here in a few minutes. One more option to post your question into the chat pad. If you want that. And it's also a good opportunity for you to like the video, subscribe to my YouTube channel if you like what I'm doing. Click the like button, click the notification bell, and most importantly, share this video with your friends and families if you know they have loved ones in intensive care. Share it to someone who knows that needs help. Right? we are getting results for our clients and their families. And once again, you can look that up on our intensivecarehotline.com podcast section, where we've done client interviews, and you can look up our testimonial section at intensivecarehotline.com. And you can see what our clients say there. Next. So I want to wrap this up. So once again, if you go to intensivecarehotline.com, we have a membership there for families of critically ill patients in intensive care. You can get access through the membership link or through intensivecaresupport.org directly. In the membership, you have access to me and my team 24 hours a day in the membership area and via email, and we answer all questions intensive care related. I also do one-on-one consulting and advocacy over the phone, Zoom, Skype, WhatsApp, whichever medium works best for you. And I talk to you and your families directly. I talk to doctors and nurses directly. I handhold you through this once-in-a-lifetime situation that you simply can't afford to get wrong. We also do medical record reviews in real time. We also do, so that you can get a second opinion in real time, we also do a medical record reviews after intensive care if you have unanswered questions, need closure, or if you are suspecting medical negligence. And all of that you get at intensivecarehotline.com. With intensive care at home, we are sending our critical care nurses into the home 24 hours a day, and we are replicating an intensive care bed in the community, predominantly for long-term ventilation, tracheostomy, BiPAP, CPAP ventilation without tracheostomy, tracheostomy without ventilation, home TPN, home IV potassium, home IV magnesium infusions, home IV antibiotic infusions. We're providing port management at home, Hickman's line management, central line management, PICC line management at home. We are providing PEG tube, nasogastric tube, and nasojejunostomy tube management at home. We're also providing ventilation, tracheostomy, weaning at home. We're also providing palliative care at home. We are an NDIS-approved service provider all around Australia, DVA all around Australia, TAC and WorkSafe in Victoria, iCare in New South Wales, and IISQ in Queensland. And our clients have received funding through public hospitals, departments of health, and also private health funds. So check that out as well. We're also providing level 2 and level 3 NDIS support coordination. And our NDIS support coordinators have a wealth of knowledge that will help you to get the best NDIS plans for your loved one or for yourself. We're also providing TAC and WorkSafe case management in Victoria with our TAC case manager, Lucy McCodder. If you're a critical care nurse looking for a career change, please contact us. We have jobs for critical care nurses, ideally with a postgraduate critical care qualification in Melbourne, in Victoria, in Bendigo in Victoria, Warragul, Victoria, Geelong, Victoria, but also Sydney, Brisbane, so multiple locations. If you are an ICU or ED consultant, we are currently expanding our medical team as well. If you're interested, please reach out. And we also can help you in your ICU and ED, emptying some of your long-term staying beds, or you're regularly readmitting patients and you won't even pay for it most of the time. And if you're a hospital executive watching this, the same for you. If you have bed blocks in your ICU, ED, respiratory wards, we want to hear from you. Now, thank you so much again for watching. I'm going to wrap this up now. I'll talk to you again during the week with my quick tip videos and through other YouTube quick tip videos, and also another YouTube live on the weekend. Have a safe Christmas, Merry Christmas, and thank you for all your support. Take care for now.